And that's what comparative effectiveness is. Clinical comparative effectiveness is a totally different thing. We spend hundreds of millions of dollars every year paying for programs on long-term studies through the NIH to find the answers to clear questions. But to think we're going to have some ivory tower bureaucratic doctors look at the data over a short period of time and tell the rest of America what's good for them and what's wrong, that's poppycock. And what it's set up for is so that we can manage the costs, so that we can ration the cost of care in this country. There's nothing wrong with a single-payer system, but just remember the way you control the cost in that is deny care. And that's what England does. That's what France does. That's what Canada does. They deny care. We're going to make an assessment in Washington about how much your life's worth, and then we're going to tell you whether or not you can have the care. That's where we're going with this. There's no denial of that. I mean, if we're going to do cost comparative effectiveness, we're going to tell you what you can and cannot have, or what is recommended under the Washington-based insurance plan. And we're going to do that in Medicare. And we're going to do that in Medicaid. Just remember, we're rationing right now in Medicare. Seniors, if you're out there, listen to me. If you've got a complicated health condition and you need to have a colonoscopy, no longer as a Medicare patient can you have a virtual colonoscopy that puts you at almost zero risk. You now have to have a procedure that puts you at greater risk, that actually costs more. But because somebody in Washington decided that was too expensive. If you have lymphoma or leukemia or cancer and your blood count drops, don't forget that your doctor doesn't get to really make a decision about when you get erythropoietin, something to bring your counts back up, because Medicare has already decided when you can have that and when, without consideration of your concomitant other health problems. That's where you're walking with this. If you like that, if America likes that, then let's do it. But just remember, it's rationing. We're saying you're not worth great health care. I think every American's worth great health care. And I think competition in terms of professional quality, in terms of delivery of services, and competition among the insurance industry is not where it should be. And I think we ought to drive it where it should be, because I think it'll help us allocate resources. Nothing should happen to somebody like Patricia Irvin, that Senator Casey talked about. We failed. But we created a lot of the inflation in health care by cost-shifting Medicaid and Medicare costs onto the cost of private health insurance. It's at minimum $1,800 a family a year. Because we won't put the money into Medicare, we've made private health insurance cost $1,800 more per year per family. So you get to pay three taxes in this country. You get to pay your Medicare tax, then you get to pay your income tax, and then you get to pay a whole lot more for your health care, because we have government programs that we refuse to fund adequately or manage properly. That's the truth, and you cannot deny it. We have cost-shifted hundreds of billions of dollars into the private sector. The other problem that I see that I want to share is this assumption that we know best. You know, we don't. We're tasked with a mighty, mighty task if we're going to adjust health care. We don't know. We haven't begun to know what we need to know to make the decisions that have to be made on health care in this country. And the idea that we're going to do this in a fixed period of time to put a fire out with a very high risk of getting it wrong, to me, it doesn't compute. None of us want to hold up fixing health care.